Your screen's up, Krishnan. You're muted, Krishnan.
Sorry about that. Can you hear me now?
We can hear you.
Yep. Are the slides still showing?
They are. It's not in the presentation view, though.
How about now? Is that better?
Yes, it is.
Oh, yeah. So I wanted to talk a little bit today about vertebrobasilar dolichotasia. Part of this relates to some work I did as a research fellow at Mayo Rochester with Dr. Walid Brzezinski and Dr. David Kalmes. And I wanted to target this to an audience for both the cerebrovascular neurosurgeon as well as the non-cerebrovascular neurosurgeon. No disclosures. This is a short outline of the talk. I wanted to touch base on some of the underlying tenets of the pathophysiology of this unique disease, as well as some of the new advances that have come out from recent studies analyzing the natural history, touch base on some of the treatment challenges from both the open cerebrovascular standpoint and the endovascular standpoint, and where future directions might target future research efforts. So dolichoectasia refers to two Greek phrases. The first one is dolichosis, which refers to an increase in both vessel length and tortuosity, and ectasia, which is, of course, dilatation, pathologic enlargement of a vessel. And as you can see here on the images below, there is a marked difference in caliber in both of these parameters between normal and abnormal vessels. Dolichoectasia can, of course, occur both in the anterior circulation and the posterior circulation, and very rare to occur in both circulations. And here I'm focusing primarily on dolichosis and ectasia occurring in the posterior circulation with the vertebrobasilar system. There have been a couple imaging definitions that have been described. Probably the most famous one is from Dr. Smoker's paper in 1987 from AJNR. And in this paper, she outlined some radiological features based on the anatomy of the basilar with respect to the clivus. And in that paper, they used 4.5 millimeters as the definition for ectasia, with a basilar diameter greater than this value being defined as ectatic. In this paper, they provided criteria based on three separate variables, one being the diameter based on the distribution of basilar diameter in millimeters, the laterality of the basilar, so that's either medial or lateral with respect to the clivus, and then the height of the bifurcation, whether it was above the suprasellar cistern at the level of the third ventricle or pushing on the floor of the third ventricle. In a subsequent paper by Dr. Zaidat, approximately 15 years or 17 years after in JNNP, they actually used MRA to describe some further radiological characteristics and see how well these correlated to Dr. Smoker's original criteria. In their series based on MR, they defined basilar ectasia as vessel diameter greater than 3 centimeters with a lateral deviation greater than 1 centimeter. And that was, if you drew an imaginary line, that was going straight up from the bifurcation, and anything perpendicular or any deviation from this basically was defined as dolichoectatic for the basilar. For the vert, they used what they found on MRA was a slightly smaller diameter as expected, with just under 2.4 centimeters. And here they found that any portion of the distal vert or VB junction that arose above the pontomedullary junction would be classified as dolichoectatic based on MRA. The risk factors for VBD are similar to risk factors seen in certain other cardiovascular and cerebrovascular pathologies, including aneurysm formation. The cardiovascular risk factors include the typical non-modifiable risk factors of age and male sex, as well as smoking and hypertension. And importantly, there are non-cardiovascular risk factors, namely vessel wall diseases such as Marfan's, Ehlers-Danlos, as well as certain other metabolic conditions, such as the glycogen storage disease, Pompe's disease, and the lysosomal storage disease, Fabry's disease, which people maybe remember from USMLE Step 1, and autosomal dominant polycystic kidney disease that have been associated with dolichoectasia in general, and specifically with vertebrobasilar dolichoectasia. The prevalence of dolichoectasia was previously thought to be underreported, and a recent Nature Reviews, or relatively recent Nature Reviews neurology paper by Dr. Gutierrez, seen here, categorizes a range of prevalences pushing upwards of 5%, which is relatively high. The prevalence of VBD in patients presenting with an ischemic infarct can be as high as 17% in a series of studies from the late 90s, and recent literature suggests that this might be slightly lower, probably on the order of single-digit percentages. So it's sometimes portrayed as a very rare esoteric condition, but these prevalence values would kind of suggest that it isn't. The underlying pathophysiology of vertebrobasilar dolichoectasia is disruption of the internal elastic lamina of the basement membrane, which you can see here in this asterisk on the Masson trichrome stain. And similar to saccular aneurysm formation, the underlying molecular pathophysiology relates to an imbalance between proteinase degradation of the basement membrane and production of basement membrane proteins, specifically fibronectin. The fundamental enzymes related to this are matrix metalloproteinase, specifically MMP4 and MMP9, which have been shown on a few recent papers on qPCR to be overexpressed in pathologic samples obtained from patients at autopsy that have died from aneurysm, from ruptures due to VBD. Two of the other fundamental tenets in the formation of these vascular malformations is the presence of remodeling, not just in the basement membrane, but also in the other layers of the vessel wall, and most markedly is seen in the tunica media with smooth muscle cell deposition. And there's evidence that suggests that not only does hypertrophy occur due to the hypertension, but there's also deposition of new smooth muscle cells along that layer that result in thickening. The relationship between blood pressure and shear stress has been established for decades in the cardiovascular literature. And we know that any increase in vessel shear stress essentially stimulates the tunica, both the media as well as the intima, to allow to promote secretion of certain mediators from the endothelium and disrupt the nitric oxide balance within the endothelium. The fundamental endpoint in vertebrobasilar dolichoectasia is, like I mentioned previously, the degradation of the internal elastic lamina. What this does, it weakens and lengthens the arterial walls and results in the characteristic imaging findings you see of a tortuous dilated vessel spanning from the VB junction upwards. The inciting event in VBD patients has not been as concretely described as it has for saccular aneurysms. We have suggested from certain recent Japanese studies, of which this is one of the foremost one, although this is now almost more than 20 years old, that an intramural plaque hemorrhage similar to a coronary plaque inciting event may be what results in this luminal thrombosis. You can see here on the histopathology side at autopsy that there's disruption of the internal elastic lamina here at this layer, and you can see thickening in the neighboring tunica media as well. The presentation of VBD, in fact, most commonly is incidental. The two other most common presentations that have been seen are ischemia from thrombosis to perforating vessels coming off the basilar most commonly, with infarction being one of the most common symptomatic presentations. Mass effect is the other most common symptomatic presentation. As you can imagine from the previous images on the first slide, there can be substantial mass effects on the brainstem at the pontomedullary junction, as well as onto the cranial nerves. And in fact, presentation with cranial nerve compression syndromes is a not often uncommon phenomenon, in particular hemifacial spasm. And as you might have expected from the CT criteria, with mass effect on the third ventricle being one of the criteria for characterizing VBD, hydrocephalus is another presentation commonly seen in VBD. Subarachnoid hemorrhage and even intraparenchymal hemorrhage remain less commonly seen as presentation. This is a cartoon from that Japanese paper from about 20 years ago, and it just outlines some of the underlying pathophysiology that's seen with these dolichoectatic vessels. On the left, this is trying to depict the normal basilar. So you see the basilar here, and we're looking from ventral to dorsal with the fourth ventricle here, and the pons here, and middle cerebellar peduncle on the left and right side. On the right, with dolichosis and ectasia, you note that the basilar has enlarged, of course, and is now shifted to the right side. Because of this, any thrombosis that occurs within the lumen from stasis and increased shear stress results in ensuing blockage to downstream pontine perforators. And there's two mechanisms by which this arises. One is from the increased shear stress and the increase, a reduction in laminar flow and turbulent flow at the ostia of the perforators. And second, simply due to the longer distance circumferentially that the blood is now traveling through. The natural history of VBD for quite a while was poorly understood, and Dr. Fleming at Mayo Rochester provided some key papers in the early 2000s, from 2004 to about 2008, that described an extensive cohort series what the true natural history of vertebral basilar dolichoectasia was. In this paper from 2005 in cerebrovascular disorders, they characterized the annual 5-year and 10-year risks of infarction. And as you can see, there's a near exponential increase in infarction rate with VBD when going from 1 year to 5-year risk. And the risk of recurrent infarction is not insignificant at almost 7%. Dr. Fleming, in a prior JNS paper, also described the prospective risks of hemorrhage, which was characterized in their paper from 2004 as 2.3%, with a 2-person year per 1,000 person year incidence of subarachnoid hemorrhage, as well as 11 for intracranial hemorrhage, with the caveat that ischemic presentation still remains the most common symptomatic presentation with VBD, arguably. More recent paper from Dr. Vergoen in the Netherlands, who was actually one of the senior authors on the phases score paper for sacral aneurysms. In this 2013 paper, he outlined some of the 5-year ischemic stroke risks, and these recapitulate Dr. Fleming's work, showing a 5-year ischemic stroke risk of 17%, with a much lower subarachnoid hemorrhage risk of 2.6% at 5 years. And importantly, we know that the degradation of the internal elastic lamina is progressive and results in progressive symptoms in the majority of patients. This was an interesting paper by Dr. Picot, who's a French, I believe, interventional neuroradiologist, that looked, and in this paper in stroke from a few years back, they look at the basilar artery diameter in a longitudinal cohort, and they were able to characterize the actual increase in mortality from ischemic events with each millimeter increase in basilar artery diameter that you see depicted in the table on the left. Each 1 millimeter increase in basilar artery diameter was associated with more than 25% risk in stroke mortality. And as you can see on this table, the all-cause mortality in their cohort of just under 200 patients was 35%. Dr. Shapiro and Dr. Nelson in New York, Dr. Shapiro being the author of the website Neurangio, provided a recent systematic review from 2016 looking at essentially the natural history literature in VBD, as well as fusiform vertebral artery aneurysms in general. And their results were sobering. You can see from their table 4 in their cohort, this is looking at only the cases of vertebral dolichoectasia, the overall mortality in their overall systematic review cohort, which comprised, I believe, just under 700 patients from pooled studies, was 43%. The mortality from ischemic stroke was 14%, and the mortality from hemorrhage was 6%. And so these results emphasize the morbid nature of this disease and the need for targeted intervention, though the prevalence, as alluded to at the beginning of this presentation, remains relatively low compared to other cerebrovascular pathologies. This was an interesting paper from Dr. Brzezinski from 2017, and this kind of provided some of the paving way for some of the work I was doing with the computational fluid dynamics on vertebral basilar dolichoectasia when I was at Rochester. And essentially, they had a cohort of patients. I think this paper they used 10 patients where they were able to generate flow-related models and use these models to ascertain the specific vessel wall physiologic and engineering variables that have previously been described in saccular aneurysms. And the findings were similar to what was expected. So most notably, the wall shear stress wasn't markedly different between aneurysms that were just deemed stable versus unstable. The most important finding was that the velocity was substantially lower in unstable vertebral basilar dolichoectatic aneurysms. And what this suggests that the fundamental pathology remains loss of laminar flow and conversion to turbulent flow, which promotes thrombosis within the vessel, as well as dissemination of thrombosis within these pontine perforators. What I was working on as a project was primarily looking at wall shear stress and maximum velocity in a small cohort of these vessels. The treatment indications for vertebral basilar dolichoectasia remain arguably somewhat controversial, given the relatively poor natural history of this disease, as you can see here from the prior studies, with essentially a 40% mortality rate and a 17% ischemic stroke rate in 5 years. And of note, this is a 17% ischemic stroke rate in the posterior circulation in a region that is, of course, extremely unforgiving for an ischemic event. And so the current paradigm has largely, or the prior paradigm has largely been to offer treatment when the rupture risk, as estimated from these prior studies, is substantially higher than any morbidity from any endovascular or open intervention. The identification of patients who convert from stable, so-called stable aneurysms to unstable aneurysms remains, in my opinion, one of the fundamental questions for vertebral basilar dolichoectasia. And typically, the identification of high-risk patients has been due to symptomatic presentation. As you can see here, so this is a recent case report. I wanted to show some of these images here, just to emphasize how much mass effect can be placed on the brainstem from these lesions. You can see here these large, partially thrombosed dolichoectatic basilar on MRA on the right. And you can see here the near complete effacement of the lower pontomedullary junction. And I didn't show the other figures that show the third ventricle, but there was marked obstructive hydrocephalus. Treatment has comprised of 4 separate categories, with conservative management being either observation or initiation of either antiplatelet or anticoagulant therapy. To date, no real robust retrospective or prospective study has demonstrated any marked benefit to using antiplatelet or anticoagulant therapy for these lesions. And the 2 historical interventions for these lesions has remained microsurgical treatment or open microsurgical treatment or endovascular intervention. Unfortunately, even despite the use of, or the introduction of flow diverting stents with FDA approval in 2011, treatment has historically remained only partially effective or markedly morbid. And I'll outline some recent series and some historical series to demonstrate that. Medical management has historically considered of aspirin monotherapy with addition of a cholesterol lowering agent, systolic blood pressure control, and when necessary, placement of a shunt for symptomatic hydrocephalus. And as you can see here, these are kind of drops in the pond to see if the natural history can be outraced. And oftentimes, unfortunately, these simply don't work. Microsurgically, as you can imagine, these lesions are formidable. Clip reconstruction is very, very rarely possible and typically not possible at all. Not only are these lesions extremely difficult to access surgically, given their ventral and low location, with depending on where the VB junction is, the nature of extent making surgical access difficult, but also simple clip reconstruction wouldn't be sufficient to stop flow going anterograde unless these lesions were focally eccentric, which rarely is seen. Historically, Hunterian ligation was the primary method by which these were treated. This is the original series from Dr. Drake at the University of Western Ontario and his series of 14 patients that he published in 1975. And what he essentially did was ligate, as you can see here, some of the cartoons, was ligate the vessel proximal to where the dolichoectatic lesion was. And essentially you were relying on the PCOM for continuation of flow. His results from the technical standpoint, this is his table 1 here, on a total of 21 cases. He also included some more fusiform, pure fusiform aneurysms in his series. His results from the technical standpoint were good. Unfortunately, it was difficult, even despite in his hands, to beat the natural history of these formidable lesions. The other microsurgical option that garnered substantial attention in the late 90s was arterial transposition. And this was to relieve some of the mass effect on the lower cranial nerves. This is Dr. Spetzler's series from the late 90s. And he comprised a series of just under 40 posterior circulation fusiform aneurysms, of which 11 ended up being pure dolichoectatic. And in this, what they outlined was their experience with vessel transposition. Again, similarly, though their technical successes were applaudable, the clinical status of these patients, particularly long-term follow-up, remained poor, as you can see here from the Glasgow outcome score in some of these patients. Management strategies to date after these series have thus largely comprised of parent artery occlusion with adjunct bypass. One of the bypasses that has been commonly used in recent series from Japan, the States, and Europe is use of a radial artery interposition to plug into a PCA and basically work towards flow reversal with vert sacrifice. Typically, these have largely been approached through far laterals. In Dr. Drake's original series, he approached pretty much all of those lesions, all those 14 lesions, through far lateral, with 2 cases that he supplemented with essentially a transpetrosal approach to get more caudal to cranial access. And historically, these were the type of procedure that were performed with hypothermic circulatory arrest. Dr. Drake temporarily clipped 3 of the lesions in his series, and those 3 patients subsequently ended up experiencing, unsurprisingly, massive pontine infarcts and dying. 2 recent series, one from Dr. Spetzler and one from Dr. Lawton, Dr. Spetzler's series being from about 12 years ago, have outlined their respective surgeons' series and experience with the use of clip reconstruction with bypass. This is Dr. Spetzler's series that he published in 2012. It's relatively small, comprises 11 patients, but it has a very nice diagram that illustrates his use of the PCA bypass So in this case, he was using an extracranial to intracranial bypass for addressing these dolichoectatic lesions. And as you can see here in figure E, figure C, demonstrates the single barrel bypass, and figure E demonstrates the double barrel bypass that was plugged in. In this case, he had one limb of the SDA plugging into the P1, P2 junction, and the second limb going to the SCA with the clip construct as you see below. Dr. Lawton published probably one of the most interesting and comprehensive papers in 2016 on his experience treating these aneurysms, with a very nice insight into his rationale, his thought process for treating and approaching these aneurysms. And similar to what we described, his main indication for these aneurysms had been symptom severity or change in symptom severity from mild to more severe. In his series of 37 patients, this was treated over a 17-year period, so again, underscoring the relatively low prevalence of this disease. In each of these patients, he sent the 3D reconstructed angiograms to an engineer that he worked closely with, and they were able to perform computational fluid dynamics and essentially simulate a bypass on each of these aneurysms when surgery was indicated and considered for surgical planning. And so if you look at his series of 37 patients, there were three approaches that were used, and this was similar to what was used by Dr. Spetzler in his paper. So one was essentially a combination that I described a couple slides ago. This was basically a staged endovascular and open treatment approach where the vessel would be sacrificed with coils, and essentially they would try flow reversal with a extracranial to intracranial bypass, usually using a orbitozygomatic cranie to plug the SDA to either the superior cerebellar artery or the PCA in a single barrel or double barrel construct, as this diagram from Dr. Spetzler outlined. This was the initial approach that was used for probably about the first 10 of these patients. And essentially what they found that this wasn't enough to stave off the formation of thrombus. And the majority of these patients, only 2 of those patients ended up being MRIs 0 to 2. So that means only minimally dependent on another person for their activities of daily living. And 8 of these patients ended up succumbing to severe pontine infarcts due to the presence of thrombus formation within the construct. What they shifted to after this in the later 90s and early 2000s was a flow reduction approach. And in his hands, he was using an intracranial to intracranial bypass, using the vert and plugging this to the superior cerebellar with the inner position. He most commonly used the radial, but would also use the great saphenous when available, done via far lateral. Unfortunately, even despite placing these patients sometimes on dual antiplatelet therapy with aspirin and Plavix or aspirin ticagrelor, the thrombosis rate was still unacceptably high. In most recent years, stemming from about the mid-2000s onwards, his approach shifted to what was essentially the creation of a surgical PCOM with an MCA to PCA construct using, again, most commonly a radial or saphenous interposition. And this was done also by an OZ approach with improved ischemic complications, but still at the cost of hemorrhagic complications postoperatively. This is a diagram, a very nice diagram that he had in his paper, and he outlines some of the 3 constructs that he used, and he describes historically the 3 phases of evolution of these surgical approaches. Initially with phase 1 being this extracranial to intracranial bypass that was used by, essentially that he kept using from Dr. Spetzler's time, flow reversal, transitioning to this intracranial bypass model in phases 2 and 3. And the point here is that even despite, even in Dr. Lawton's hands, the patients unfortunately don't do well. So a final follow-up, the percentage, so this is an ordinal analysis of MRS, and the far right of this diagram unfortunately is cut off, but green on the bottom is MRS 6. So MRS 6, for those who are not as familiar, is dead. So as you can see, more than 50% of these patients were 3 or worse, with a quarter of the patients dying despite these heroic and creative bypass constructs. And this is to underscore the morbid nature of these lesions, despite what was described in their series as 100% technical success of anastomosis. Even in Dr. Lawton's hands, these patients unfortunately do poorly, just given the natural history of these diseases. Endovascular management historically has focused on a combination of stenting with stent coil constructs, with the goal being reconstruction of the vertebrobasilar system. The idea with stenting is to try and straighten the tortuosity that is seen, and the main goals with stenting not only relate to straightening of the vessel, but the reduction of the turbulent flow and trying to reduce the wall shear stress that the small perforators are experiencing at their ostia to increase the flow through them and to maintain their patency. The ultimate balance is between flow and thrombosis when approaching these endovascularly. Unfortunately, prior to the flow diverting era, the devices largely limited the options available to interventionalists at the time. Historically, coil sacrifice with adjunct bypass, a combo flow reduction technique as previously described, was used as a mainstay where coil sacrifice of the vessel was undertaken. With the creation of stent retrievers in the early 2000s, namely the Solitaire, the paradigm started to shift to use of a combined stent coiling construct, and also included more stents commonly used for intracranial work, including the Enterprise and the Atlas stents. The introduction of flow diverting stents really revolutionized the approach to these lesions endovascularly. The goal, of flow diverters being the delayed progressive thrombosis within the fusiform aneurysm while maintaining the patency through side branches, and ultimately relying on intimate wall apposition to allow for intraaneurysmal thrombosis and endothelialization along the stent struts where they're opposed to the wall. And historically, since flow diverters were introduced, these have been used in what's called a telescoping fashion to maximize the degree of wall apposition throughout the pathological disease segment of the vessel. Original flow diverters, these are from kind of the mid-2010s, were unfortunately too short, and so interventionists at the time, initially starting with Dr. Siddiqui at Buffalo, started telescoping these devices, one within each other, to maximize the degree of stent apposition. And that's what you see here on the unsubtracted angios on the middle and right panels. And so these are flow diverting stents that have been telescoped within each other, as you can imagine a telescope being extended to maximize coverage and to ensure or to hope that there's no areas of poor wall apposition over where the devices may have end-to-end overlay, and so to allow them to overlap. The Pipeline Vantage with Shield technology, which came out, I think 4 years ago, is a new generation of pipeline device, a pipeline flow diverter with a larger diameter, so greater than 6 millimeters. And here you can see a 3-dimensional CT view that shows the 2 of these devices telescoped. I think 3 of these devices actually telescope within each other, with the overlap down here in this dolichoectatic basilar. Initial results with flow diverting stents were relatively poor, largely because of ischemic complications. There were 2 fundamental theories as to why these were occurring. One is that the device coverage, when this increased to 48 in terms of the porosity of the braids, one theory was that the device coverage simply wasn't enough to keep perforators open, and that perforators were occluding due to coverage, or perforators were occluding due to persistent thrombosis along the stent struts. The second complication that was described originally by Dr. Siddiqui in his first paper outlining the use of flow diverters for these lesions was massive delayed hemorrhagic rupture, which was commonly seen in flow diverter placement in the cavernous ICA and other locations. And what this was thought to result from in the vertebrobasilar system was from a ball valve mechanism where flow was reduced going anterograde, but the jailing, or the lack of jailing of certain small vessels meant that there was siphoning of flow, and that this would allow patency and increase the pressure within the fusiform dilated segment and increase the propensity of rupture. What you note here on this series of 7 patients, this paper was from the initial flow diverter era back in 2012, is that the sizes of device remained very small as a function of what was available at the time. Some of the other reconstructive strategies have been a combination of flow diversion with adjunct coiling, combination of stents with adjunct coiling, but ultimately what has been seen over the last few years is that these devices are associated with elevated risk of ischemic morbidity and often don't necessarily address the fundamental issue with flow coming at the cost of thrombosis. This was another series published in the mid flow diverter era in 2016, also coming from Buffalo. And this was a consecutive case series that they published, and it also comprised of a systematic review of the literature that was available at the time, again, in the early flow diverter era. And this is just to underscore the elevated rate of ischemic and hemorrhagic complications that have been occurring as well with deployment of these devices. One of the recent papers that also came from Dr. Siddiqui's group, as well as work from the Barrow, identified that compression against the brainstem was one of the most important risk factors for stability of these lesions. And so this was one of the variables that they described in their paper as being important for deciding offering treatment versus non-offering treatment. Should treatment still be offered in a markedly dolichoectatic aneurysm without evidence of symptomatic brainstem compression, but only radiographic brainstem compression? Most recently, this is a neurosurgical focus paper from just last month, actually, coming from a collection of people spearheaded at Pittsburgh. And this is a direct systematic review and meta-analysis comparing head-to-head open surgical intervention with endovascular intervention to assess what the true complication rate in a meta-analysis of proportions was. And the data is not really granular to provide a head-to-head comparison. They're comparing series from open cerebrovascular surgery that date to basically Dr. Drake's series onwards in the 1970s, and comparing that to endovascular papers that have been published in 2016, 2015. So arguably not comparing apples with oranges necessarily, but at any rate, I think it provides useful prevalence and incidence rate on complications seen after treatment with these lesions. As you can see here, the ischemic stroke rate with surgical intervention remains high, again diluted with or amplified by early series where the treatment approach at the time remained Hunterian ligation. Future directions, I think, really should work on addressing the patients that would warrant treatment. As you can see here, treatment is a formidable effort, either endovascular or microsurgical, and identifying patients whose natural history exceeds procedural morbidity remains one of the fundamental questions that has to be answered. The other thing that Dr. Lawton's paper from 2016 illustrated is the use of patient-specific models based on reconstruction from three-dimensional angio and use of computational fluid dynamics for analysis of these lesions. Computational fluid dynamic analysis have been used for anti-circulation aneurysms more in the academic setting to drive device design and to also analyze what the risk factors for aneurysm patency and failure to occlude after device treatment are. But in the posterior circulation, there hasn't been really much work apart from a scattering of papers, possibly due to lack of interest and, of course, the essentially off-label use of these devices, flow diverters in particular for the posterior circulation. And finally, in terms of device design, larger diameter flow diverting stents, which have recently been introduced with the pipeline Vantage at 6 millimeters, may provide another tool in the armamentarium of the neurointerventionalist for targeting these lesions. Thank you.
Krishnan is an excellent talk. Dr. Talk, do you have any comments or questions?
So a great review, Krishnan, basically, especially with the pathophysiology and morbidity of this disease. But dolichoectasia is perceived and taught as a benign condition. Fusiform aneurysm of the VB junction or vertebrobasilar system symptomatic. I call them the GBM of vascular, basically. And I think there is a spectrum of this disease from the start to the end, and which patients are going to evolve into this fusiform is where the need to focus on, basically, risk factors and those kind of things. Because once those patients become symptomatic, as you showed a very nice review of the literature, is that even in the hands of Spatzler and Lawton, there is no good outcome. Even with what they do in Buffalo, there is no good outcome. So this sets a kind of bar where we see that none of those treatment has worked historically for those patients, and it's a really tough disease. I think, I mean, your review was excellent. I mean, you have literature in and out in this talk, so I congratulate you, and I encourage all the residents to look at those reviews, because once you look at a disease, you have to understand where it works and how does it manifest and those kind of things. I personally think that we are getting those patients at a too late of a stage to intervene on them. And I'm still puzzled to see what would be the solution for those patients. It's mostly flow problem. It's not, and it's the vessel wall falling apart and whatever you do. I don't think, to be honest, flow diversion is going to be the solution. That's how I personally think, because you know, you can't line up a flow and eliminate the flow outside the flow diversion device without consequences on the deep perforators. But this is a spectrum of a disease. We see patients where it's just an image finding. We see some patients with very mild diplopia from 6-nerve compression, and they correct with a prism, and they live many years like this. Once the vessel starts falling apart, I call it get out of the way, just a train derailing. And as a treating physician, the hardest part for me has been to provide treatment for those patients that is safe, because whatever we do, those patients are going to encounter a problem, and it's going to count to your surgical morbidity. I remember a patient where my colleagues in neurology were also very afraid of any treatment, and we ended up, I mean, the patient ended up going to hospice without a treatment, and we saw him week after week coming back, the Coumadin, the blood thinners, and nothing worked for him. So it's almost like a GBM of vascular, and it's going to be very challenging to cure this disease. But I think the key is going to be early identification and some sort of understanding flow dynamics, stabilization of the vessel wall, keeping their blood thin, and some reduction, and working on their blood pressure. I don't know. I see many other people. I'll open it to other questions.
Robbie, I have one quick comment. This is Misha Plesnor, ophthalmology. I have interest in this. Have a interest.
So Misha, you're going on and off in silent mode.
Yeah, Misha, we're having a little bit of difficulty hearing you. It's Dr. Miller. Do you have any questions or comments?
No.
First of all, before we start, the conference code, since all of you may not be logged in, is, what is it again? TEP TEPLUW. Sorry, go
I have a
ahead.
quick comment, if I may. This is Misha Pless from Neuro-Ophthalmology. Fantastic talk, Krishnan. Amazing. Great review. I have a personal interest in carotid dolichoectasia and how it relates to optic nerve lesions. There's a burgeoning field of interest in the types of optic neuropathies that's caused by the the sister vessel or brother vessel, if you will, in terms of axonal attrition over the years, causing something that has been labeled as normal pressure or low tension glaucoma. And if anyone in your group is interested in looking at this together with me, I'd be very happy to share my my collection, my thoughts.
Thank you, sir.
Great.
That's very interesting. I didn't touch on anterior circulation dolichoectasia here, but I think both in the anterior circulation and the posterior circulation, like Dr. Talk said, we simply don't understand the flow dynamics enough, particularly in the posterior circulation where there's minimal room for error and basically no forgiveness with the perforators coming off to the pons. We don't know what level of flow can be reduced that will still maintain patency through perforators without any clinical sequelae, unfortunately.
David, any final thoughts,
Yeah,
questions?
again, Dr. Ravindran, great talk. Very interesting thing. Very interesting subject. Of course, there's lots of difficulties. I have a little bit of difficulty in the in reconciling everything with thrombosis along the wall as an underlying condition. It may or may not be, but very often we see in the vascular world these thromboses tend to cause more isolated or more focal problems. And this would be with these very long segment oligoectatic things, it's possible that this starts a long cascade, but I'm not so sure whether we understand, as we all pointed out, whether we understand the real origins of this as well. I agree that the answers are going to be difficult, and the surgical stuff has been very poor. I've done a couple endovascular treatments, as I'm sure Dr. Talk has, with not so great results in the long term. Technical results, yes, but long-term results not so good. But I think there may be a role for some kind of endovascular device, and yet it may be not necessarily something that it may be something impregnated. It may be stem cells. It may be medically treated things to sort of stabilize the wall. I think there are some possibilities to try and stabilize the wall, and I think for right now that's maybe the best chance we have for at least making a difference in the near future. But again, great review, interesting topic.
Thank you, sir. And there's a question in the chat regarding polygenic risk scores to identify and stratify high-risk patients. And unfortunately, no, there hasn't been any score reported or any analysis looking at a score and proposing a score. And that's one of the things I wanted to emphasize in point one of the future discussion, future directions, is that we only have a handful of diseases. And as of now, no genome-wide studies and no polygenic analyses that relate to the pathophysiology of VBD. This is kind of in contrast to cerebral aneurysm pathophysiology, where we've had much more attention and much more literature that's discussed some of the genomic variations that lead to the formation of saccular aneurysms.
All right, Krishnan, great job. Thanks, everyone. Have a great day.